Hi everyone, I'm Gavin Horrigan's Director of Research Operations for Cabrini Research. I'd like to welcome everyone who's zoomed in for this Cabrini Research session, and to begin by an acknowledgement to country. So we acknowledge the Burrarung and Wurundjeri clans of the Kulin Nation, who are the custodians of the lands and waters upon which we meet, both virtually today, and we pay our respects to their elders past, present and emerging. I'm standing in for Gary today because he's on annual leave. So without further ado, I would like to present to you our first presenter, which is Dr. Leo Chen. Leo is a consultant psychiatrist with an extensive experience across clinical research and medical education settings. He's the head of the clinical TMS and psychopharmacology research teams at the Monash Alfred Psychiatry Research Centre, MAPRC. He's the director of psychiatry training at Alfred Health and a senior research fellow at the Department of Psychiatry, Central Clinical School, Monash University. Leo is passionate about improving the quality and efficacy of treatments for persons living with mental illnesses. To this end, he is an investigator on numerous clinical trials involving pharmacological agents and brain stimulation techniques. His research in TMS and its application to treat depression has been presented at local and international scientific conferences and has published widely in peer-reviewed journals. So Leo is going to be talking about functional connectivity-informed, individualised transcranial magnetic stimulation therapy for anorexia nervosa, which is the function trial. So I will turn over to you, Leo.
Okay, thank you so much, and thanks, Gavin, again for that kind introduction. So I'm Leo Chen. I'm a psychiatrist and have been working in this space for probably the best part of about 10 years now. Originally, mostly in novel therapeutics and brain stimulation therapies to treat depression. That was sort of the focus of my research for a long time, and it still is now. And, you know, over the past 6 to 12 months, I've been delving very deep into the anorexia nervosa space, and it gives me great pleasure to be talking about a trial that we've finalized the protocol for, and that will be rolling out over the coming months. And I think the translational neuroscience that informed the trial conceptualization, the study conceptualization, hopefully will be interesting. It sort of brings together clinical psychiatry as well as electrophysiology and brain stimulation, as well as neuroimaging, particularly functional magnetic resonance imaging, or fMRI. Thank you for Gavin also for stating an acknowledgement to country. So I will bypass that part. By way of disclosures and declarations, I have no stock or equity interests in any medical or clinical businesses or any medical device manufacturers. Over the slides to come, you might see pictures of medical devices. They're just there for my convenience. It's not because I'm marketing any of them. I'm completely device agnostic. I do have a general psychiatry private practice, of which brain stimulation techniques like ECT or TMS feature. I'm also a member of the International Clinical TMS Society Education Committee, and every now and then they invite me to give talks or teach into courses and offer me an honorarium for that. And my current research is funded by philanthropy and previously by institutional sources. So anorexia nervosa, I'll go through the background fairly briefly because I know that my colleagues will speak to them, and Dr. Goldschlager, a expert in eating disorders, can do justice to this landscape much better than I can. But I'll maybe touch on a few things, and some of the audience might have come across this documentary that aired at the start of the year. You can still find it on ABC iView. It basically sort of provided an expose of people living with anorexia nervosa in Australia and follows the stories of young people like Sarah, who you see here on the screen, and the daily distress and the daily difficulties and the challenges they face living with this condition, and the challenges they have with accessing services, accessing effective services, and a lot of anxiety about maintaining their health. And we know that persons living with anorexia nervosa, they've particularly been impacted during the COVID-19 pandemic, and we think to a large part that may be related to the impact of lockdowns and inability to divert their activities to school, to play, to job, to spending time with their friends. And, unfortunately, the phenotype, if you like, and the symptoms of this condition really took hold for some people. Again, I won't speak to this in a dot point fashion because, I'm mindful of the time, but perhaps I'll just touch on a few particularly big ticket statistics in this space that really resonated for me. Number one is that we've known for a long time now that anorexia nervosa has got the highest mortality rate of all psychiatric disorders. Number two is if you're a young woman living with anorexia nervosa, you are 10 times more likely to die relative to your peers prematurely. If you're a young woman living with anorexia nervosa, you're about 60 times more likely to die by killing yourself compared to your peers. This is not a very encouraging, state of affairs. And, we have very, very limited therapies for this condition. Our treatments often don't work very well. And it's not without, a want for trying. It's not because there haven't been effort put into this field. This is very local information and publications in the Australian College of Psychiatrists journal. About 10 years ago, 15 years ago, there was an initiative that brought online a body image eating disorders treatment and recovery service, and they published their initial outcomes about 10 years ago, and the short-term treatment outcomes were fairly okay, but in terms of attrition of patients who go on to follow up as a day patient, and the degree of engagement that the patients had with these specialist services, their ability to maintain their weight. This data just wasn't so encouraging, and I'm not presenting this paper because I want to highlight some of the deficits, but more because the same group from the University of Melbourne and St Vincent's Hospital and Melbourne Health had published a follow-up commentary just last week, I think a week or two ago, talking about, well, where to from here, and things are still not particularly as good as we'd like them to be. We need more services, etc. So this is a space where there is a lot of need, there is high mortality, high distress, and we really need to do something about it. Sorry about the box that's sort of not transitioned as I had liked, but in summary, this was a systematic review and meta-analysis of all randomized trials comparing all interventions for anorexia nervosa, whether it be medications, whether it be family therapy, whether it be refeeding regimes, you name it. As long as it's a randomized trial, it was included in this meta-analysis. And on the left-hand side, they reported on weight restoration at follow-up, and on the right-hand side, which I know is partially obstructed, they reported on the psychological outcomes. So fear of eating, mood, anxiety, symptoms, etc., obsessionality that can be expected in this disorder. And I think the forest plots speak for themselves in that, the treatments that we have, whether it be olanzapine, whether it be citalopram, whether it be certain types of therapies, they are just not that effective. unfortunately, with the exception of, for example, like a tube feeding regime for the purposes of weight restoration, but we know that's highly, highly traumatizing and highly unpopular with our patients. And on the right-hand side, as far as the psychological symptoms go, we know that psychological treatments such as CBT may have some short-term effects and maybe some follow-up effects of moderate effect size. So the authors of this study that came out of California surmised that cumulatively these results imply that overall interventions that address psychological mechanisms of anorexia nervosa are failing to demonstrate treatment effects, and it underscores the need to explicate illness mechanisms and target them in novel precision interventions. We need to actually work out what's going on, for us to be able to treat this condition, hopefully with a little bit more optimism. So in terms of thinking about, novel approaches and new paradigms and great ideas, I'm going to draw on neuroimaging as a source of innovation and inspiration as well. I think this is important to talk about, and I think this is a worthwhile avenue to pursue because unlike, say, about 10 to 20 years ago, nowadays our neuroimaging technologies have come so far. It's really been a game changer in allowing us to understand the brain better. We're obviously visualizing the brain better, but actually appreciate and understand functioning of the brain and being able to ascribe pathophysiology based using brain scans. The oncologists have been using this for a long time, using nuclear medicine studies. The neurologists and the surgeons have been using it for some time already. This is one paper that was published in the Australian GPs journal. That was a bit of a primer talking about functional MRI, what it is, what it does, how you can apply it in clinical practice, and why GPs need to know about it. So in effect, functional MRI is a higher definition form of MRI scans where it provides greater spatial, so higher resolution, as well as temporal, so timing resolution of the person in the scanner. It obviously is applied to neuroimaging because in other parts of the brain, just a structural scan or an anatomical scan should be enough. But in neuroimaging, the functional connectivity between different regions can be crucial. So just to explain this a little bit further, in that figure there, on the top right-hand side, this was describing how functional MRIs are utilized in neurosurgery. There is a 60-year-old man who's got a brain tumor, as you can see here. I hope people can see my mouse cursor. You can see the brain tumor here, and they conducted a functional MRI scan and saw there was correlation, because these are all lighting up in red. There was correlation lighting up along this patient's cortical spinal tract. You've got your primary motor cortex that links to the cortical spinal tract. It basically is the circuit that controls your limbs. And the tumor sits separate to the cortical spinal tract, and the surgeons were like, okay, so we can go ahead and operate. If they hadn't done that, or if they hadn't done that and the tumor did actually go through that tract and the surgeon operated, you could render that person with paralysis or with hemiparesis or loss of limb control, right? So the surgeons have been using this for quite some time. You see in figure 2 down the bottom, and I know I'm sort of talking through this at a fairly sort of hawk's eye level, but in figure 2 you see similarly tumor that needs to be resected, but it just so happens that this tumor encroaches on the arcuate fasciculus, which is one of the white bundle tracts that connects the language centers of the brain. So the surgeon said, well, look, we can't actually operate on this, because if we did, we'll render this person mute. They won't be able, yes, we'll take the tumor out, but we might make that person unable to speak or move their lips again. Right. So, there is a clear reason to do this for surgical reasons. So you might ask, okay, well, that's great, but how is it applicable to psychiatry where we're not resecting parts of the brain? And how is it applicable to anorexia nervosa? So I'm going to introduce a couple of my friends and colleagues. These are Dr. Shan Siddiqui and Joe Taylor. They're psychiatrists at the Brigham and Women's Hospital in Boston, and they both work at Harvard University. And they have a very long-standing track record. Them and their seniors and their bosses and professors have a very distinguished track record in the study of brain connectomics, basically the study of brain networks and connectivity. They've published extensively and studied this field extensively, and, established that when we're trying to establish functional connectivity between region A and region B for surgical reasons, sure, you can see that, this is clearly outside of the margins of a tumor, it's in neurosurgical purposes, it's fairly straightforward, but in psychiatric purposes, it's not so straightforward. Let's say if you did get positive correlation between two brain regions that light up on a person's fMRI scan, it's very difficult to infer whether region A has caused a problem in region B, or is it region A that's causing symptom X or behavior Y? There is no causal influence. So this is the work that they've been doing extensively for the past 10 years, to address what in the literature describes as the causality gap in functional neuroimaging, to overcome this. Where the field has moved to is really looking at, okay, so you actually have to identify causal lesions, and that way you can ascribe causal inference to that functional network. So, what I'm saying is, for example, if someone was caught up in a car accident and they sustained a brain injury in, let's just say, the, left ventral medial prefrontal region of the brain, and subsequent to that, the person has developed depression, or the person has developed anorexia, or the person has developed some other psychiatric syndrome, you can then say with a degree of certainty in that person, it's because of damage to the VMPFC, that's what's caused this behavioral syndrome, right? We're now at a level of imaging and computational sophistication that this can be done fairly readily, but obviously, it does demand a high degree of technical expertise. So, these guys are part of our research network, and we, communicate frequently. And, Joe shared with me towards the end of last year, they did a systematic review of all the causal lesions that caused de novo anorexia nervosa. So these reports were people who did not have anorexia nervosa before, but because of some brain injury, a hemorrhagic stroke, a foreign body, a brain tumor, because of some injury, they've developed anorexia nervosa behaviors, and they were able to find 15 cases. They mapped them out all to a healthy brain atlas, and laid them one on top of the other to see where were the parts that were overlapping, because obviously, different people will incur different brain lesions at different parts of the brain, right? The lesions were spread heterogeneously, but when you map them sort of like carbon copied one after the other, you can start to see a pattern of where some of the common sites are that, connect circuits of connecting a circuit involving all of these lesions. And perhaps not surprisingly, that it zoned in on a part of the brain called the lateral hypothalamus, because we know this is one of the feeding control centers of the brain. But perhaps what took us a little bit by surprise was just how homogeneous this was. All 15 cases, when you map them to functional networks, they all corresponded to the networks all went through this part of the brain, all went through the lateral hypothalamus. So, Joe was like, okay, well, maybe this is coincidental and maybe it's too good to be true. So he then compared this functional network pattern with 1,000 healthy controls and found that this network, and particularly a positive correlation, a positive functional correlation with the lateral hypothalamus, did not light up in people who did not have anorexia nervosa. So all of a sudden, we've found this circuit that is highly sensitive and highly specific, particularly for people with anorexia nervosa. And again, I emphasize that causal inference is what's important to recognize here. So the next step of, having derived this circuit is that we need to find, well, that circuit could be running, I'm sort of drawing a sagittal circle around the side of my head, through the camera. But, we need to be able to find where we can modulate, where we can tap into the circuit, where we can modify the activity or stimulate this circuit. And by using non-invasive brain stimulation modalities such as transcranial magnetic stimulation, we can target cortical regions of the brain. So as long as, the area we're trying to target with TMS is, not more than about 1 or 2 centimeters below the level of the scalp, we can induce changes in activity and connectivity levels in that part of the brain. And of course, the brain is, a very, very electrically active and connected organ. So, if you're, for example, modulating the part of my brain that's above my left eye, but it's also the part of the brain that's connected to a circuit that you want to reach deeper in my brain, it's basically sort of plugging an appliance into a power socket, and you can still derive power from the electricity that runs throughout the house or throughout the street, right? So this is the premise of what we're trying to do. We need to find, therefore, a cortical target that maps to this specific causal network. We've had a series of meetings about this. And you have to pardon my attire on this screenshot from a Zoom call. We were sort of coordinating time there in Eastern Daylight Time in Boston, and it was sort of mid-afternoon, beautiful sunshine, and it was like 6 a.m. for us in winter, and it was really cold. And I had my beanie on, and when I first joined the Zoom call, Sean said, "Why does it look like you're about to rob a liquor store?" So, you have to pardon the beanie. At least, I was fully dressed for work because it was definitely a work meeting. We were able to find cortical targets that were functionally correlated or functionally connected to this deeper anorexia circuit. And I'm just going to go between a couple of screenshots, and I'll explain what I'm doing as I say so. So we were just having a play with the mapped lesion circuits of 4 participants or 4 patients reported in the literature, 1, 2, 3, and 4. So you're looking at the functional connected brain region of patient number 3 here, and this is patient number 4. So once again, 3, 4, 3, 4. They're all connected to the anorexia network that we want to tap into, and there are overlaps in the cortical targets that we can identify. In this case, the left parietal region is a scalp target that seems to be lighting up in several of the people that undergo this imaging analysis. But of course, when we are running the trial, all our stimulation targets are individually derived from each person's individual resting state functional MRI scans. So if it means, for example, we needed to better stimulate sort of the prefrontal, this is kind of the ventral medial prefrontal area. If that's the peak correlation, and that's probably what's going to get us best results, we can do that. We're effectively completely individualizing a treatment protocol depending on that person's individual brain scans. So that's a very rapid fly through of what we're doing. We're really excited about this project. This is the first time that we are using a causal lesion mapped network that is specific for any particular disorder, whether it be anorexia or anything else, but we're also deriving a functionally connected cortical target from individuals' brain scans. And we're proposing that we provide non-invasive brain stimulation treatment over the course of about 3 weeks, and shorter courses of stimulation over months 2 to 6, and hopefully see if some of the key measures in our studies, such as BMI, eating disorder rating scale findings, psychological ratings, and quality of life ratings will improve. And we're also coupling that with a consumer co-designed qualitative evaluation of their experiences over the course of their participation. Thank you very much. Thank you very much.
Leo, just one very general question on my part. I couldn't help noticing when you put up the slide with the meta-analysis that most of the dates of those studies were pretty recent. I think 2004 was the oldest, and a lot of them were in the last 10 years. Just in terms of anorexia nervosa, I mean, is this something that's always been there but not talked about? Or is it something that, has become more commonplace in recent times?
I've just put the slide back up. Is this the slide you were talking about?
Yeah, that's the one, yeah.
Yeah. Look, this is actually, and Romy will be so much more qualified than me to speak to this, but I think she would concur with, and we did not choreograph this beforehand. I think she would agree with me in saying that this is a condition that's time immemorial. This has been around since ancient Egyptian times. Into the sort of the 18th, 19th century, start of the 20th century, people thought it was a strange form of neurosis. There have been, European royalties who's been described in historical archives to have this strange malady where they just stopped eating and became more and more frail and died. So this is a condition that's been around for a long time.
Okay, thank you.
But it's a condition that also has received very little research attention. And as you say, Gavin, a lot of the studies are recent. But I mean, I would also argue that a lot of the studies are recent because, this particular systematic review was only looking at randomized trials, and randomized trial methodology was something that really came more into the fore, right, from the 1990s. So if that wasn't an exclusion criterion, I mean, if you just looked into the anorexia literature, you can easily see case reports, case series, open label trials, etc., of from the 60s and the 70s of anorexia studies. But the rigor of translational neuroscience and derivation of clinical trial evidence base nowadays are so much more rigorous. We're really looking at randomized trials, controlled trials as a gold standard.
Thanks, Leo. So the next speaker on my list is Evelyn Mew, who's going to talk about novel treatments in complex post-traumatic stress disorder. And just in the way of background, so Evelyn's a research fellow at the Her Centre. Her research focuses on women's mental health, including depression, anxiety, borderline personality disorder, complex post-traumatic stress disorder, and eating disorder across the lifespan. Her interests include understanding the role of trauma in the etiology of borderline personality disorder and developing innovative diagnostic tools to improve the diagnostic accuracy of borderline personality disorder. So I'll turn over to you, Evelyn.
Alrighty. So I've been positioned nicely between my two colleagues who will be talking about anorexia nervosa, but I'll break it up a little bit and shed light on a complex and often misunderstood mental health condition, borderline personality disorder, also known as complex post-traumatic stress disorder, and the trials that we're trialing, and the medications that we're trialing at Her Centre Australia. So, bit of a background, borderline personality disorder is a condition characterized by intense emotional experiences with unstable relationships, self-image disturbances, and impulsive behaviors. Many of these people engage in self-harm due to low self-esteem, want to express or release emotional pain, or even to punish themselves. And this behavior is often mistaken as being attention-seeking or manipulative. And in relationships, they tend to have a push and pull dynamic where in 1 minute they will love and idolize an individual, and the next minute they're totally hating that person and thinking they're the most awful human being to exist. And they show significant anxiety and mood disturbances, as well as engage in impulsive behaviors such as disordered eating and high use of drugs. It is crucial to understand that the BPD does not arise from a single cause, but rather a complex interplay of genetic, neurobiological, and environmental factors. Individuals with BPD tend to have a history, and they are more likely to develop the condition themselves. But as I said, genetics alone does not determine the development of BPD, and they interact with other factors that create vulnerability that increases the likelihood of the disorder manifesting. Childhood trauma is another environmental factor that we see has a powerful influence on developing BPD. And we know that childhood trauma can have a severe and lasting effect on an individual's mental health. A lot of our work at Her Centre Australia is studying the relationship between trauma and psychiatric conditions. So with BPD, many studies have found a significantly higher prevalence of traumatic experiences during childhood, such as physical abuse, emotional neglect, and sexual abuse compared to the general population. And also BPD individuals often report attachment disturbances, particularly disrupted or insecure attachments, relationships with their parents. So when we consider the environmental factors of childhood trauma, attachment issues, and genetic vulnerability, the interactions is significant. When we're talking about trauma and BPD, so is there an overlap between PTSD and BPD? And the answer is yes. There is a new category called complex post-traumatic stress disorder that is identified in the ICD-11, but not in the DSM-5, which is a diagnostic tool that clinicians use. The classification debates continues, with some arguing that trauma is not involved in BPD and that it's just a personality disorder, while others agree that trauma plays a big role in developing the symptoms. Unfortunately, despite the significant correlation between trauma and BPD, many clinicians do not inquire enough about trauma and during assessments and treatment. And this oversight can hinder accurate diagnosis and appropriate interventions. Currently, individuals with BPD are often prescribed antidepressants to help with the low mood stabilizers to help with the fluctuation of moods, or even antipsychotic medication. So in this time point, there is no medication as first-line treatment for BPD. So we believe that if we were to consider trauma in BPD, we can better understand the neurobiology and have new treatment approaches. The chronic stress from childhood trauma can induce changes in glutamate release and overactivation of the NMDA receptors. And in fact, several lines of evidence support the involvement of glutamate in the cognitive and affective disturbances in BPD. So given this, it is clear that NMDA receptor paths might be relevant to the etiology and treatment of BPD. So the PI, Professor Jayashree Kulkarni, proposed to use memantine, which is an uncompetitive, low-affinity NMDA receptor antagonist that selectively blocks excessive NMDA receptor activation. Memantine is currently approved for treatment of Alzheimer's disease, but studies have found promising results of memantine in treatment of schizophrenia, autism spectrum disorder, bipolar disorder, which shows similar symptoms to BPD, and also alcohol abuse and withdrawal. In our trial, we're currently conducting a 12-week clinical trial to determine the clinical efficacy of adjunctive memantine for BPD, and we're predicting that taking memantine will show greater improvement in symptoms compared to placebo. In the trial, participants who are randomized to memantine, we start them off on a 10 milligram dose for 7 days, and then we titrate that up to 20 milligrams for the remainder of the trial. We're just about to submit our first manuscript, and here I'm sharing with you the longitudinal change in symptoms for the memantine and placebo groups. A lot of numbers there, a lot of stats, but as you can see, we're finding that pretty much all symptoms relating to BPD are improved in the memantine group compared to the placebo, who do show improvement, but definitely not as large as the memantine group. And as you can see with the different measures that we're using, these measures are specific in measuring BPD change, and it looks at the different subtypes of BPD symptoms as well. So it's all good and well when we get statistical significance. It's what we want for research papers, but I think the more impactful from my point of view is the feedback that we get from patients. So as you can see, a lot of the theme that we're seeing is that it's helping people regulate their emotions. It tends to act as a circuit breaker for people to stop, reassess the situation before emotionally reacting. A lot of people reporting clearer thinking. So again, the drug is for Alzheimer's disease, so it's no-brainer that it would target the cognition. And a lot of people just reporting that this is the drug that they think it is for BPD, and what it's acting on is going to be different to the antidepressants that haven't been helpful so far. Now, focusing on the neuroendocrine system. So both the neuroendocrine axes have been reported in the abdominal BPD and indicating that neuroendocrine system as a potential therapeutic treatment for BPD. Specifically, the cyclical fluctuations in ovarian hormones affect emotional and cognitive behaviours relevant to BPD. The efficacy of use of estradiol treatment as a novel clinical treatment in women in psychosis has been demonstrated in our world-class studies, and we now have promising clinical pilot data and clinical case report data indicating that estradiol may improve key symptoms in women with BPD. So in this trial, we're investigating the use of ovarian hormone estrogen to reduce the symptoms, and we're using estradiol in a gel form, and the layout of the project itself is similar to the memantine one that I spoke about briefly before. So it's a 12-week trial. And this trial is in the early stages of recruitment. So unfortunately, I can't share any data with you at the moment. But again, I guess we can draw from the participant feedbacks that we're getting, and they're consistently reporting improvement in mood, which we figure estrogen will target more for. And also, again, that it's targeting mood that, again, antidepressants have not been useful for them in the past. So watch this space for this one. So yeah, those are the two current trials that we have in borderline personality disorder and complex PTSD at Her Centre Australia. If you know of anyone, patients, relatives, friends, or whatever it may be, who are interested in trialling these medications, please reach out to Her Centre Australia at monash.edu or give us a call. We're just located on St Kilda Road.
Thanks very much for that, Evelyn. That was a great presentation. Anyone got any questions for Evelyn?
Gavin, can I ask something?
Yes.
Thank you for the presentation. You mentioned, it was very well presented, thank you. You mentioned the memantine trial you achieved in BPD. You showed some beautiful, significant results already with only like 33 patients. I didn't quite take in that full slide. What was your primary endpoint in that study? And sort of how has the study been powered to try to find a difference in addressing that particular endpoint?
Yep.
So are you looking like for 500 patients, or what are you trying to do in the long term?
Yep. So our primary outcome is looking at the ZAN BPD, which is a key rating scale that we use in BPD research. And we're tracking these individuals fortnightly for symptom changes, but mainly for the data that I showed you earlier was comparing from baseline to week 12. In that group, we've got about 30 individuals for that paper, and we're finding significant differences at that low number. In our power analysis, I believe we anticipated 50 in each group. I need to look back on the numbers, but with the interim analysis and what we're showing now with our stats, it's proven to be significant. So we're quite confident that it will continue to reach significance with a higher sample size as well.
We'll move on to our final speaker, Dr. Romy Goldschlager, who's going to talk about the THREAD, which is the transformative hub of research in eating disorders. So Romy is a psychiatrist with interests in complex trauma, eating disorders, addiction, psychiatry, chronic pain, psycho-oncology, psychotherapy, and family therapy. It's quite a lot, Romy. So she's worked at the eating disorder unit at John Cade Level 2, and looking there, she's looked after several patients with eating disorders in a CL setting, and is currently working with the Alfred Ramsey Partnership on the statewide Women's Mental Health Service to develop a hospital in the home program for adult patients with eating disorders. So I'll turn over to you, Romy, to talk about THREAD.
Okay, so as Leo talked about, anorexia nervosa is a kind of very serious condition. It has one of the highest morbidity and mortality conditions of the various mental illnesses. And unfortunately, we do not have very good treatments for it at all. So most of the treatment for anorexia nervosa is actually targeted in the young adult population, people who are living with their families. It's called family-based therapy. And studies of family-based therapy report anywhere from 50 to 60% response to that treatment, and some studies report higher up to 90. But even if it was 90% response to family-based therapy, it's a very specific type of therapy that isn't well suited to all patients, and it's certainly not suited to the older population of adults that we're working with. Really, family-based therapy focuses on bringing the family together and using them to weight restore a patient with anorexia nervosa. So feed them to get the person up to a healthy weight, and that's really the mainstay of that treatment. And so really we're in this space where there has been very, very little research done in the area. Like Leo said, often when we're doing our research, literature search, there might be 4 papers on a particular treatment, some that show it's effective, some that show that aren't, and they're very, very small sample sizes. So there's really very little evidence out there around what therapies, specifically pharmacotherapy, could be used in this treatment population. Anorexia, I think, traditionally has been seen with a lot of stigma. It's often been seen as an interpersonal or a social illness. So a lot of people will tell you that 10, 20 years ago, when their child had an eating disorder or anorexia, they as a parent were blamed for inducing that illness in their child. And we've heard that a lot in mental health. The same thing happened with schizophrenia. And also a lot of the time, anorexia nervosa is blamed either on the patient themselves for being too preoccupied with how they look, or also a social illness, that it's due to our societal norms on thinness. And I think that some of these stigmatizing interpretations of anorexia have actually contributed to why there's such a poor understanding of the biology that underlines it. There are a lot of factors related to anorexia nervosa that make us think that there is a strong biological component to the illness. So we know that separate to any environmental factors, anorexia nervosa certainly seems to have a genetic component too, and can run quite strongly in families that have a history of anorexia or other eating disorders in those families. We also know that starvation in somebody who doesn't have a history of an eating disorder can actually cause very similar symptoms to what we see in several of the eating disorders, and it's especially anorexia. So that rumination about food, thinking about it constantly, getting into very strange rituals about food, starting to worry about your weight and your appearance can actually arise de novo in somebody who's experienced starvation, who can then almost develop this secondary anorexia nervosa. We also know, as we can see in the key focus of family-based therapy, that reversing somebody's malnutrition can in itself treat the symptoms of anorexia nervosa. So we start to think, well, what's happening biologically there, that the starvation in some way is causing the anorexia, and when you treat the starvation, a lot of the cognitive and psychological symptoms of anorexia nervosa are reversed. We also know that the rate of mental illness in anorexia nervosa with comorbidities is very high. Up to 50% of people often have other mental illnesses, and some of the ones that we see quite commonly is trauma, which is going to relate to how we've designed our study, and combining some of the processes that Evelyn was talking about in the BPD study. We also know that there's a lot of overlap between anorexia nervosa and addiction psychiatry. And alcohol and other drugs of addiction. And also we see what's really interesting is that there seems to be two peak waves in terms of the onset of anorexia nervosa. So most commonly it starts in young women around the age of 14, 16, which also happens to be when young women are going through puberty. And we do see a second wave that occurs in the perimenopausal group of women. Anorexia doesn't only affect women, but certainly the two peaks where its onset is in women is interesting and leads to potentially some hormonal underpinnings to the illness, or leads us to wonder about that. This shouldn't. So what we are setting up is a 12-week double-blinded randomized placebo trial to look at repurposed medications added to treatment as usual in a group of patients with anorexia nervosa. There's actually 2 or even 5 separate studies that we're talking about at the one time now. But basically what we're going to be looking at is thinking about, well, a lot of patients with anorexia nervosa do have a history of trauma or complex trauma. So can we look at the medications that we've previously seen to be effective in this group of patients and see if they're also effective in our population of people with anorexia nervosa, adults with anorexia nervosa. So we're looking at brexpiprazole, which is an atypical antipsychotic, and it has both agonist and antagonist effects at the serotonergic and dopamine receptors. We're also memantine, given that it was so effective in the population of patients with borderline personality disorder, which is an NMDA antagonist. The other treatments that we're thinking about that could be useful in this population is based on this model of the dietary deficiency. So thinking about, well, if there's something related to the malnutrition that's causing the symptoms of anorexia nervosa, could, by correcting those deficiencies, could that reverse the effects of anorexia? So we're looking at butyric acid, which is a short chain saturated fatty acid, and we're also looking at zinc. So there have been a little bit of research looking at zinc maybe 20 or 40 years ago that found that some certain preparations and doses of zinc could be effective at helping people to increase their weight, but there hasn't been further evaluation of that in bigger populations. So that's what we'd like to look at. And also then the fifth arm, or the fifth study that we're looking at, is could this be a hormonal imbalance given that it's happening at those two peaks for women? So in a group of women with anorexia nervosa, we'll look at replacing their estradiol and seeing if that can help treat the illness. The first 4 studies are open to any adults with anorexia nervosa regardless of gender, whereas that 5th study will be targeted only towards women. So already we've had a lot of interest from members of the population about this, and I think that's because it is such an awful illness that not only affects the person but their entire family, and people are desperate. There hasn't been a lot of research and there aren't effective, quick treatments that are available. So people are definitely keen to find something that's out there. But again, if you have people that you think might be interested, please direct them to contact us, because we are going to need quite a number of participants, given that we are testing out 5 different treatments and a placebo group as well. So that's everything that I had.
Thanks very much, Romy. How long do you expect this trial to take?
So we're aiming to do it for 12 weeks.
Mm-hmm.
And certainly with the estradiol group, we're expecting to see results quite quickly. The study from the zinc trials, I think, showed effects quite quickly as well in terms of the increase in weight restoration. And that's what we're really hoping to look at, because often patients with anorexia nervosa are in treatment for years before they start to see results or changes in their illness.
Yeah. And would recruitment be staggered?
Evelyn's nodding. I think with the process of it, with protocol and ethics, I think the TMS is the closest to start off first. Then soon after, either the estradiol or the 4-arm trial that Romy reported.
Okay. Does anyone else have questions for Romy?
I'll ask something too, Gavin, if I may. Making
sure.
better. Thanks, Romy. Obviously, the condition is very diverse in terms of severity, with mild, moderate, severe. Where do you think the treatments are in the long term going to be? Are we going to be mainly attacking people very early in the piece or late in the piece? Which way do you think it's going to head?
Let me just clarify the question. So in terms of offering treatments early to people
Yes.
before they develop severe illness,
Yes.
that's certainly something that we want to look at with the trial. Is, are people who respond, we'll do a sub-analysis to look at length of illness, and is there a difference between people who have had the illness for, say over 7 years, which defines them in the severe and enduring category? To answer exactly that question is, does treatment need to be started early? Can treatment still work if they've had the illness for 10, 20 years? Certainly, we know currently the earlier you can get somebody into treatment, the better outcomes that they have.
If you had a crystal ball, Romy, where do you think we'll be with this in 10 years' time?
Hopefully we'll have a magic pill and we'll have eradicated anorexia nervosa.
Yes, nothing like eradication. Any other questions? If not, I would like to thank the three speakers that we've had from MAPRC Her Centre. Fantastic talks. Thank you so much for presenting your work. Really interesting. And and because of the trial nature of this, all three of you can come back and talk at some stage in the future and tell us how it's all going. So it's wonderful. Just before we close off, I'll just mention that obviously we've started advertising the Cabrini Annual Research Forum. So this is an opportunity to showcase the work that's being done across Cabrini. We're at the process at the moment where it's still called for abstracts, which runs until the 23rd of July. So if you'd like to showcase what you're doing, I strongly encourage you to do that. And in terms of the next session, I think it was scheduled to be Wednesday, the 2nd of August. However, that's dependent upon the speaker being available. So we'll certainly keep you informed as to when the next session's on. So thank you, everyone, and have a great day.